And will they only work in community health centers, or they will start having their own practices and work everywhere? That's something, again, worries the doctors. Then representative of NMC, more than 70% are non-elected. But what did the elected members do beforehand? Again, question can be asked. Then the single national level exit exam can create trouble. Again, time is not there to discuss all the details, but we have to look at all. And something that is worrying all is frame the guidelines for determination of fees and all other charges in respect of 50% of the seats in private medical institutions and deemed universities. So what will happen later on to the remaining seats? Then tenure, 5 years to 4 years. Only good thing about this is, unlike MCI, the members of NMC will have to declare their assets at the time of assuming office and when they leave. They will also have to submit a conflict of interest declaration. So I think this is the clause should have come long back even in MCI, and maybe MCI would have improved at that time. So the next legislation is telemedicine. I'm not going to go into the details of it, but 2020, the pandemic actually made it mandatory for this legislation to come in, and now it's accepted and working well. And so that's a relief to the doctors, because we also can do teleconsultations in many of the situations, especially for the patients who we are already examined and seen, and patients don't have to travel all the way. So these are the issues that we need to look at when we consider any telemedicine thing, and how we are going to do that remotely. These are the kind of evidences or communications will be there. There will be real-time communication. There will be just sending the reports and other kind of communications under this. But these are foreseen and they are allowed. So patients may consult with the doctor. Whether you want to consult it directly as a first consultation, it's up to you. It's your responsibility when you do that. Then, now the latest that is going to come in is National Digital Health Mission. Now this is absolutely, if you look at it, this will be absolutely an idealistic, ideologically great move. When will it happen? How will it happen? We'll have to wait and see. And so if it happens, it will be a great, great thing, because a patient can go anywhere and any place, and the data of the patient will be available directly there. You put in a number, patient's identity number, and you will get the whole data right from childhood to what happened to this patient anywhere and everywhere. But so this is a very, very ambitious scheme that the government is working on and may come in eventually at all. Then some of the practical issues that we have to work on is one, MTP Amendment Act. And this is something, again, is fairly new. 2021 it came in. This gave additional help to the women. And I think when we look at, and when we compare, overall health sector, not only in our country, in other countries, I think even compared to US, which is going back as far as the, this law is concerned, we are really progressive. And that's why what this has brought in is now the termination is allowed up to 24 weeks, and in rare cases even after that. And so when it is allowed and how it is allowed, I put it in the table. I will not read through it. But in this situation, up to 24 weeks, and this was long coming and it was needed, that survivors of sexual assault, minors, women who experience change in marital status, women with physical disabilities, women living with mental illness, pregnancies where fetal malformation is substantial risk of being incomplete, and pregnant women in humanitarian settings have been now allowed to avail of termination up to 24 weeks with just the two doctors consultation and opinion. Then this is again an important part, failure of contraception. It was to be availed only by married women before. Now even single women can avail of this indication of failure of contraception. MTP pills were allowed up to 7 weeks. Now this amendment makes it's allowed up to 9 weeks. So these are substantial and important changes that this bill has brought about, which will be really helpful to women out there. But there are some barriers also that some are existing, some have been. So especially, a board has to act, especially after 24 weeks termination, you have to take permission from a medical board. That's one barrier. And second, the POXO Act, which was there, what POXO Act says is any sexual activity, if a doctor comes to know before that patient has either indulged or have gone through sexual activity before age of 18, then that has to be reported to the police mandatorily. And that creates a problem, because if 17-year-old girl comes, and even if she's not pregnant, but if if you come to know that she has indulged in, say, sexual activity or has been taken advantage of, then you're supposed to directly inform the police. And this creates barrier for termination in these situations. ART and surrogacy bill, again, two more important legislations that have come in recently. This ART bill 2020, and in July 2019, surrogacy bill came in. Very important bills, needed a lot of changes. The ART services have been defined properly in this. The registration of ART clinics and banks, the boards have been created for this, and eligibility criteria for commissioning parties. As you see, for ART, it's 21 and 50 years women's age, and 21 and 55 years men's age. And eligibility for donors is 21, 55. Lot of small tricky situations are there. Again, there is no time to go through that. But mainly what we find here is that the definition of infertility in these bills is also different. So, so that also creates trouble. So, this is a surrogacy bill that has come in. So clinics providing surrogacy are granted registration for 3 years, while ART bill is for 5 years. The requirement of ART clinics and banks to share personal information can create trouble, because this is to be sort of put in the national registry, and these registries are always likely to leak. So the term infertility is defined differently, the boards are different, and registration process is not the same as earlier. Age criteria mentioned are different in eligibility, and offenses and punishments are differently explained. In surrogacy bill, storage criteria was 25 years for the case papers, and in ART bill it is 10 years for case paper. So unnecessarily creating trouble, in this situation, which could have been easily sorted out if I think people would have put together their brains in a little better manner. And of course, finally, the Rajasthan Right to Health, the controversial bill. This is the bill that came in. This is what it states. This is a statement from that bill. All patients can have emergency treatment care, and you can go through that and read. What does it sound like that? And this is exactly what the IMA interpreted it as, that anybody can walk in any hospital saying that I'm getting pain in abdomen and it's an emergency, and that patient will have to be given free treatment. And that's why doctors were so much agitated and they came on the streets and fought for it. Now the issue is, again, all these is actually, you have probably read, this is actually the IMA document that came in. A little bit of, misconception also was there, but always we fear what happens on the ground, and that's why, all these issues were raised, So the explanation by government was there that, the definitions are there in the Act, and you need not worry about things. So definition of emergency as accidental emergency, emergency means accidental emergency only. Emergency obstetric care means to treat and therefore save the life of a woman. So very cleverly, put in, explained. But again, what we are worried about was the ground reality, especially this word, stabilize the situation, transfer the patient on your own kind of things. So there is no actual provision for reimbursing a private health establishment for providing healthcare services. Nothing was mentioned about, how they are going to provide. The budget was not increased to the state. So, the establishment covers are there, mandatory registration, minimum standards. Believe me, regulation of costs of services is also there. So this is there in the 2012 Act. And what did we do about it? We were not probably aware. Half of us were not aware that this Act is already there, passed long back. Then medical, this is a new thing that the government is bringing on. It's central government is going to give grants to states to bring on more medical colleges, that in the hope that it will solve the issue of dearth of doctors everywhere. Then Uniform Code of Pharmaceutical Marketing Practices was brought in, and this code governs the pharmaceutical companies. Now again, when we look at this and when we complain about whatever is happening around us, and what my previous speaker was also alluding to in a way, that this code establishes the relationship with healthcare professionals, wherein provisions related to travel facilities, hospitality, and cash or monetary grants to physicians or their families have been elaborated. Why did it have to be done? Who was responsible for this? We need to introspect also. When we ask for our rights, we have responsibilities also. And that's why, we have to look at this also closely, and that's where the debate can also, start. And of course, it also covers irrational combination of drugs as well as irrational use and means to regulate marketing practices and so on. Then National Medical Commission. Now this is we are going into the real legislation part of it. This is something that has been brought in comparatively new. What is the NMC bill? It replaces the MCI. Now why did the MCI had to be replaced? I think many of you know more than what I can tell you, that we all wished at some time that it needed to be replaced. Whether we got a better deal or worse deal, that you have to all decide looking at this. So National Medical Commission will have 25 members appointed by the central government. A search committee which will have 7 members will recommend names to the center for the post of chairperson and the part-time members of NMC. Peculiarity is all the 7 members of the search committee, including the 5 experts, will be nominated by the center. And the NMC is to frame policies for regulating medical institutions, medical professionals, and frame guidelines and so on and so forth. So it's a much wider sort of legislation, allowing much more governance to NMC than the MCI had before that, right? So there is an advisory council. There is going to be a bridge course, and this bridge course is one of the biggest changes which the NMC bill will bring about. Dentists, Ayush and homeopathic practitioners, paramedical students and others will be allowed to take a 6-month crash course in practical medicine. On completion, the trained students could be allocated the post of doctor at the healthcare facilities. Then there is this next examination. First, the NEET examination came in. This NEET examination had its problem, and that's why the next has come in, which is final year MBBS exam as an entrance state for post-graduation examination. All these, the problems difficult to solve. They have their own issues, but people are trying to solve some problem, and I think more and more inputs need to be brought in. So what is worrying the doctors about the NMC? That, this Section 32 authorizes the government to allow non-medical degree holders practice medicine in community health workers. So what is going to be their status is definitely a worry. Can you learn everything in 6 months? It was said that, you spend from your own pocket, and then, we'll see that there. We know even for so many central schemes, like central government schemes and all that scheme, people have to go to Delhi to get their own money, which they have already spent. And you know how that difficult that is, and it takes sometimes year. So for small emergency or 1 or 2 emergency cases, who is going to go? That nobody thought of. So the comments are these definitions should not be kept open, emergency and stabilization. 90% of doctors who are clinic-based are not capable of handling any life, threatening emergency other than the first aid that is there, and so they should not be included in all that. And only maybe general surgeons, if at all, and gynecologists can handle the obstetric emergencies if time comes, And so, the obstetric emergencies cannot go anywhere else, but only. So this has to be specified, mentioned, and it has to be a dire emergency, very specifically mentioned. Then only this will be acceptable. And this is not new. In the Pandit Katara's case, Supreme Court has also says that if there is a roadside accident, any doctor who is there, it's his duty, and we also agree that it's our duty to take life-saving measures, and we always do that. And so this was probably, if you consider, entirely superfluous, and you know what is the purpose why these bills are brought in. It's entirely ulterior motives in these situations. So the government needs to at least double its health budget and public health systems capacity. Overall, this act is ill-prepared and fails to take into account the practical realities of the system. And that's why, we should oppose it, but we should oppose it correctly in a better manner, again, taking up every single issues, thrashing it out in the courts, going up to the Supreme Court. It may take time, it may require an effort, but we need to put in these efforts. And of course, the latest change, just a couple of days back, these 2 additions are there. Good thought, adding of nursing colleges. We have terrible dearth of nurses in the setups, and that's why more the better. I think this, though late, is a very welcome step that has been brought in. And of course, this is again something that came in very, very important, because again, practically all our equipment is imported and costs us a lot, and that's why this issue is also quite welcome. So finally, what I would like to say is India needs a holistic and socio-economic approach to manage the problems within the healthcare industry. It can be done by including the collaboration of all private as well as public stakeholders and also individuals. The healthcare industry is continuously witnessing growth, and this wide scale of growth also introduces several challenges. Not only individuals, but also this industry itself sometimes faces problems by this wide area of development. Apart from it, managing the dual disease burden, as we know, should also be a priority. The nation can be fit and healthy only if the healthcare is made easily and universally acceptable. A major reform that is needed for legislative reforms is to seek more collaboration from the private sector, as has been said. And sir, namaskar. I'm really privileged to welcome my teacher, Dr. Muzumdar sir, for this August gathering. Just the last slide. And so major reform that is needed for legislative reforms is to seek more collaboration from the private sector, mainly the doctors who are actually practicing in various different fields on the ground, recognize the ground realities, improve the governance, plug the corruption. We are always, from public dais, why are we not calling corruption corruption? It's there, and we have to keep on saying that this needs to be improved, and to make the dream of ideal healthcare of our citizens. So final word, I've tried to give you a panoramic view of what's happening in the healthcare reforms. And there are, as I said, there are grand designs. They're absolutely well thought of, fantastic designs. But, what happens at the ground level, we are always skeptical. But let's be optimistic. Let's participate individually in whatever we can do to improve things a little bit at our ground level, and put in our efforts also and our representations in a right manner, and don't give up on things. I always say, don't say that, this can't be done, the corruption is always going to be there, what can I do about it? Let's be optimistic, let's participate in everything that we do, and what changes that we want to be brought in, and I think then that will take us a long way and we can really improve things for our country. Thank you so much.
The last session for the day was incredibly wonderful. As a society, it's our responsibility to ensure that everyone has access to high-quality healthcare services. By supporting legislative reforms in healthcare, we can help create a healthier and more equitable society for all.
I would now request Dr. Rajiv Yeravdekar, Provost, Faculty of Medical and Health Sciences, Symbiosis International University, to felicitate Dr. Sanjay Gupte, sir.